The way to do electronic health record research right now is to take the data out of electronic medical records and to put it in some kind of analytic platform. The platform that we've developed and used for this is called I2B2, and it's been pulled into use for many different functions at over 130 academic medical centers. And in our network, we have 14 medical centers, but in the larger networks, there's well over 30 medical centers sharing data in a common format that's been removed from the electronic health record so that we can query it and find patients or query it and pull out data sets to do what's called observational research. What we're learning now in the era of what's being called precision medicine or personalized medicine is that individuals will respond to therapies differently and that individuals will have different genetic backgrounds that cause what appear to be the same condition but may really come from a different pathophysiological mechanism. So there are two ways to approach that. One is through measurements in the body, omics, genomics, whole exome sequencing to try to find the variants, but one needs to know where to look. So in what's called the phenotyping side, there's genotype, which is the genetic cause, and there's phenotype, which is how that gene manifests itself in the outward appearance and function within the individual. It turns out that within the phenotypes, once you're in a big data setting, you can actually do very interesting clustering to find phenotypes that group together. And one way to look at it is by the comorbidities that are associated with the condition. So, for example, in a project we're doing on pulmonary arterial hypertension, the cause of pulmonary arterial hypertension among children who have bronchopulmonary dysplasia in the newborn intensive care unit versus the kids who have Down syndrome versus the kids who have what's called congenital adrenal hyperplasia are all different, most likely. And even though the condition is called pulmonary arterial hypertension in all of them, it's different groups, probably different causes, probably different treatments. And so through the big data analytics, even from data that are pretty coarse in nature, like the data in electronic medical records, or even coarser data, the data in claims that are submitted to payers with diagnoses and procedures and medications, we're actually able to partition patients into very interesting subgroups that may actually represent different genetic causes of disease. So the way to get information to the clinician about something like a patient's risk for Ebola and the urgent precautions that would need to be taken around that patient have to do with, number one, understanding the risk that a patient has for important conditions. Mm-hmm. So every patient comes in with risks that are based on the geography they come from, that are based on their prior medical history, that are based on their family history or the medications they're on. And we leave it up to the individual clinician to integrate across all the information that they may or may not have available to them to figure out which risks are the most important. But there are quantitative ways to handle risk. Take geographic risk. Geographic risk is, again, everyone comes from a geography, and that geography has a quantitative risk. For example, in the case of infectious disease, how many patients have the infectious disease from that geography? That tells you what your chance is. In the case of Liberia, the chance was very high, and the consequences were very dire. So in that case, the geographic risk, which is easily ascertained from the patient's home location and travel history, could be matched up against a database that exposes risk by geography, and a decision rule could fire that tells you that precautions are very important. That decision rule could also take into account that the patient has a fever and go even to a higher DEFCON level at that point. Here's another example that's a bit simpler. Strep throat. We treat strep throat based on certain criteria, mostly based on physical exam, and the complaint of a sore throat, fever. And it turns out that there's another important factor that's sort of integrated in, but not quantitatively and not consistently, and that is whether there's strep throat going around at the time. It turns out that if you have strep throat going around in your neighborhood and you've got sort of mild symptoms, you're still pretty likely to have strep. If you've got mild symptoms and there's no strep in your area, you're very unlikely to have strep. We showed this and published in Annals of Internal Medicine as the lead article. We were able to show that if you just take into account that one medical piece of data, which is the rate of strep in the home geography of the patient, that you can much more accurately diagnose and treat strep, and that by taking into account that one piece of information, you save hundreds of thousands of doses of antibiotics per year. So imagine what we could do if we took into account all the big data that's available and used it in our decision making. Now, we've been setting up federated research networks. We have one right now that's funded by the Patient-Centered Outcomes Research Institute, and it's called SKILLS, and we have 13 health systems all sharing electronic medical record data in a common format. We put it into a system called I2B2, and we're able to query from our desktop across 13 health systems and get aggregate data, counts on patients of interest all over the country on instantaneous feedback. This is very powerful. And then if we need to do research with those patient data sets or even reach out to the patients, then we go to the institutional review boards, have a protocol, handle all the consenting issues and the ethical issues, and conduct studies. But we know exactly where the patients are, and we know exactly how to contact them once we have those regulatory approvals. Health systems are really focused on patient care more than they're focused on the learning health system. And changing that culture will take a bit of time, and one way to do it is to really think about this in an analogy to the sort of federalist system we have in the United States, where we have states that have their own interests. We have the federal government that tries to get things to happen at scale, but has to take into account the state's interests. And we really need to pay attention to the health system's interests. Now, health systems need data more and more as they take on more risk, as there's more scrutiny, as the opportunity to influence outcomes through electronic health records and software. They need data, and they need processes to manage those data. So if we can actually converge the processes that are meeting hospital business needs with those that are meeting learning health system needs, we have a real leg up on getting the engagement of health systems.